Welcome to Lesson 3. Today we're going to talk about something that should be at the heart of everything we do in public health, but too often gets pushed aside. We're going to explore social determinants of health and equity analysis. This is about understanding the causes of the causes. Why do some communities have higher rates of chronic disease? Why do some populations live shorter lives? The answers rarely lie in individual behavior alone. They lie in the conditions in which people are born, grow, live, work, and age. By the end of this lesson, you'll accomplish three objectives. First, you'll identify the 5 domains of social determinants of health. These categories help us organize our thinking about the upstream factors that influence health. Second, you'll distinguish between individual level and structural level interventions. This distinction is crucial because we often default to individual approaches when structural approaches would be more effective. And third, you'll apply structural competency principles to your program planning. This means designing interventions that acknowledge and address the systems that create health inequities. So, what exactly are social determinants of health? They're the conditions in which people are born, grow, live, work, and age. They're shaped by the distribution of money, power, and resources at global, national, and local levels. And here's what the research tells us. These determinants account for 30 to 55% of health outcomes. That's more influential than healthcare, more influential than individual behavior alone. Think about that. We spend enormous resources on healthcare and behavior change programs, while the conditions that most strongly influence health outcomes often go unaddressed. This isn't because we don't care, it's because addressing these factors is hard, it's political, it requires working across sectors, it challenges existing power structures. Let me walk you through the 5 domains of social determinants. First is economic stability, employment, income, expenses, debt, medical bills. Can people afford the basics? Second is education access and quality, literacy levels, early childhood development opportunities, access to higher education. Education is one of the strongest predictors of health outcomes. Third is healthcare access and quality, insurance coverage, having a provider, quality of care received. Fourth is neighborhood and built environment, housing quality, transportation options, safety, access to parks and healthy food. Where you live shapes how you live. And fifth is social and community context, social integration, support systems, and importantly, discrimination. Each of these domains influences health and they interact with each other in complex ways. Here's an important concept, the gradient of health. Health doesn't just differ between rich and poor, it follows a gradient. Each step up the socioeconomic ladder corresponds to better health outcomes. Someone in the middle class has better health than someone in poverty, but worse health than someone who's wealthy. This means social determinants affect everyone, not just those at the bottom. It means that addressing health equity isn't just about helping the poorest, it's about leveling the entire gradient. This is a radical implication. It suggests that as long as we have steep social hierarchies, we will have health inequities. This brings us to a critical distinction, individual versus structural interventions. Individual interventions focus on changing the person, education, counseling, skill building, behavior change programs. Structural interventions focus on changing the context, policy changes, environmental modifications, redesigning systems. Here's the honest truth. We often default to individual interventions because they're easier. We can design a health education program within our own department, but changing housing policy, that requires working with other agencies, navigating politics, building coalitions. Yet here's what we know. Individual approaches alone cannot overcome structural barriers. You can educate someone about healthy eating all day long, but if there's no grocery store in their neighborhood, education won't solve the problem. Let's be more specific about the limits of individual approaches. First, they place the burden of change on those with the least power to change their circumstances. We're essentially asking people to overcome systems that are working against them. Second, individual approaches ignore environmental and systemic constraints. They assume people have choices they may not actually have. Third, they can reinforce victim-blaming narratives. If someone doesn't succeed, we attribute it to their lack of motivation rather than the barriers they face. And fourth, research shows that individual approaches tend to produce modest, often temporary effects. When the program ends, the behavior often reverts. because the context hasn't changed. This leads us to the concept of structural competency. You've probably heard of cultural competency, the ability to understand and work effectively with people from different cultural backgrounds. Structural competency goes further. It's the ability to recognize how institutions, policies, and systems create health inequities. It's training ourselves to see upstream causes. When we see high rates of diabetes in a community, do we only think about diet and exercise? Or do we also think about food deserts, unsafe neighborhoods that prevent walking, jobs that don't allow breaks for meals, the stress of economic insecurity? Structural competency means designing interventions that address root causes, not just symptoms. It means asking different questions from the start. So, how do we apply this in practice? We conduct equity analysis at every stage of planning. We ask, who benefits from our programs? Who is left out? Are we reaching those with the greatest need? Or are we primarily serving those who are already advantaged? Could our intervention actually widen disparities unintentionally? This happens more than you'd think. Programs that require internet access, transportation, time off work, these can exclude the most vulnerable. What structural barriers might prevent participation, and how can we design around them? These questions should be asked early and often, not as an afterthought. Let me give you some concrete strategies for structural intervention. First, partner across sectors: housing agencies, education departments, transportation authorities, employers. Health is produced in these other sectors, so we need to be working there. Second, advocate for policy change at all levels. Local zoning laws affect food access, state policies affect healthcare coverage, national policies affect economic security. Third, use health in all policies approaches. This means considering health impacts in all policy decisions, not just those labeled as health policy. When a city plans a new transit line, what are the health implications? Fourth, build community power. Communities that can advocate effectively for themselves produce more lasting change than programs imposed from outside. Let's summarize our key takeaways. Social determinants account for up to 55% of health outcomes, making them more influential than healthcare or individual behavior. The five domains: economic stability, education, healthcare, neighborhood, and social context provide a framework for comprehensive assessment. Individual interventions alone cannot overcome structural barriers. We need to work at the systems level. Structural competency means training ourselves to see and address upstream causes, not just symptoms. And equity analysis should be embedded in every stage of planning, from needs assessment through evaluation. In our next lesson, we'll explore intervention mapping and logic models of the problem, tools that help us be systematic about what needs to change. Thank you for your attention.